Welcome back, Focus Learners. You know, it's pretty amazing. You've officially made it to the 10th and final part of our ICD-10-CM Chapter 15 Explainer series. Today, we're facing what I like to call the absolute final boss categories of obstetric coding, O94 and O9A. We're talking about the really complex aftermath of pregnancy complications, plus those highly sensitive scenarios involving maternal injury and abuse. We're going to break all of this down so you can synthesize everything you've learned and master these codes with total confidence.
Okay, let's dive into this. First, we'll tackle O94 for coding obstetric sequelae. Then O9A for injuries and abuse. Third, we'll decode the multi-code hierarchy. And finally, we'll bring it all together with a Master Series recap.
All right, Section 1, Coding Obstetric Sequelae, specifically focusing on the O94 category.
So the O94 category is absolutely critical when you're dealing with residual conditions that arise late after pregnancy, childbirth, or the puerperium. And here's the kicker, where the pregnancy is no longer current. I really want to emphasize that last part. For an O94 code to even be on the table, that active pregnancy state must have definitively ended. Think of it like this. You're coding the long-term ripple effects, not the immediate splash.
Because we're dealing with historical events causing current problems, your documentation needs to be completely airtight, to survive an audit. There are three absolute essentials here. First up is sequela linkage. The clinical notes have to explicitly state that the current residual condition is a direct result of a prior obstetric complication. Second, the original event. The provider must clearly name what that original complication actually was, like eclampsia or an obstetric embolism. And third, the timeline. You have to have confirmation that the pregnancy has ended. Bottom line, without clear linkage in the clinical notes tying that past complication to the present issue, you simply cannot use this code.
Now, what's really interesting about this slide is how O94 completely flips the script on everything else we've learned in Chapter 15. Seriously, normally obstetric codes take sequencing priority, right? Well, O94 is a major exception. Your principal or primary diagnosis must actually be the current residual condition. Then, and only then, do you sequence O94 as a secondary diagnosis just to designate that the underlying etiology is a late effect of a past pregnancy complication. Let's ground this with a real-world clinical example to see exactly how this sequencing rule plays out. Imagine a patient comes in with long-term heart damage resulting from a cardiac event she had during delivery years ago. Following our new rule, you would first code the ischemic cardiomyopathy as the principal diagnosis because, hey, that is the current condition requiring treatment today. Then, you follow it up with O94 as your secondary diagnosis. This clearly paints the picture that her cardiomyopathy is a late effect of a previous peripartum spontaneous coronary artery dissection. It tells the whole, accurate story in the exact right order.
Moving right along to Section 2, Obstetric Conditions with Injury, Poisoning, and Abuse, which is category O9A.
Now we need to shift gears a bit because these are highly sensitive, intensely complex encounters that require extreme precision on your part. The O9A category is specifically designed for reporting maternal trauma, toxic effects, poisoning, underdosing, or abuse. And a really crucial reminder for us all, this applies to the maternal record throughout the entire gestational period, active labor, and the postpartum puerperium. So if the pregnant or postpartum patient experiences any trauma or toxicity, O9A is exactly where you start. Just take a look at how distinct these subcategories are. O9A.2 covers your general injury, poisoning, and consequences of external causes. But then the next three branch into highly specific types of abuse. You've got O9A.3 for physical, O9A.4 for sexual, and O9A.5 for psychological abuse. It's absolutely vital to accurately reflect the specific nature of the trauma as documented by the provider. You have to clearly distinguish an accidental injury from intentional abuse. Which brings us to Section 3, the O9A multi-code hierarchy. This is probably the most complex structural challenge in the chapter, but we've got this. Let's move to and see how this builds. Because to accurately report an O9A encounter, a single code is never, ever going to cut it. We can chunk this multi-code hierarchy into 4 digestible steps to save you from cognitive overload. Step 1. Assign the primary O9A code first to establish that the pregnancy is affected. Step 2. Bring in your secondary specific S or T codes to identify the exact injury or poisoning. Step 3. Assign external cause codes to explain exactly how it happened. And finally, Step 4. You pair all of this with the appropriate Z3A code for gestational age. Let's actually drill down a bit deeper into Step 3, because external cause specifics are where so many coders stumble and lose revenue.
You need a code for the mechanism, say a motor vehicle crash. You need codes for the place of occurrence and what the patient's activity was. You need a code for the intent whenever it's documented. And this is absolutely crucial for compliance. You must apply the correct 7th character extension for those injury codes, like an A for an initial encounter.
All right, Section 4, Master Series Recap. The top 10 core guidelines of Chapter 15. Huge congratulations on making it through all the technical guidelines.
If you've mastered O94 and O9A today, you have successfully conquered the core of Chapter 15. So let's lock this knowledge in with a quick recap. Number 1, sequence first. O00 through O9A codes always take sequencing priority unless explicitly contraindicated. Number 2, trimester specificity. Always validate the exact trimester. Number 3, gestational pairing. Get in the rhythm of pairing conditions with Z3A codes. Number 4, dual coding. Dig deep for those secondary codes to define underlying etiologies. And number 5, 7th character extensions. These are mandatory for identifying specific fetuses or encounter types. These 5 rules, they are your absolute coding bedrock.
So the crucial point is really contrasting those general rules with the nuances and exceptions. Number 6, clearly differentiate between pre-existing and gestational conditions. Number 7, the diabetes nuance. Remember, diet plus insulin defaults to insulin-controlled. Number 8, delivery codes O60 through O77 are strictly restricted to active labor and delivery only. Number 9, the 2-code principle for O9A that we just talked about. Pregnancy complication first, then the external cause. And finally, number 10, the Sequelae exception. For O94, you break the primary rule and code the current residual condition first.
You know you have navigated the incredible complexities of pregnancy, childbirth, and puerperium coding. It's a lot. But before we wrap up, just ask yourself, how will the precision of your coding today impact a patient's historical medical record 10 or even 20 years from now? Your accuracy literally tells their story. Make it a good one. Thank you for completing this 10-part ICD-10 CM Chapter 15 training series. This is Decode Healthcare with Harshal.